Well, thank you, Bob, for your kind comments. This is the 120th annual meeting of the Western Surgical Association, one of the oldest surgical societies. This is the 14th meeting of the Western in Colorado Springs. In 1997, our 12th meeting here, past president Dr. Jack Pickelman addressed the society, and the title of his talk was Another Letter to the President. And he detailed his concerns about health care to President Clinton. Like virtually all of Jack's addresses, it was thoughtful, very colorful, and entertaining as he detailed proposals for Medicare recipients, medical savings accounts, the Surgeon General's role in public health, and threats to GME, all of which are very appropriate today. I've been privileged to serve as your president this year, an honor that I did not deserve, though humbly accepted. In this presidential election year, we've heard too many polarizing political statements about our high, though declining national unemployment rate, the housing crisis that's dissipating, and the slow economy. In spite of these economic and political issues, we are again reminded of our sometimes tenuous existence after witnessing yet another natural disaster in Hurricane Sandy on the East Coast. Today, my objective is to describe a precious resource that most of us have experienced that continues to be a vital part of our profession and discipline. The Merriam-Webster online dictionary defines precious as something of great value or high price, as highly esteemed or cherished, and as priceless or valuable. It defines resource as a source of supply or support, or as a natural feature or phenomenon that enhances the quality of human life. While I have no conflicts of interest and have no disclosures to make, I do have a passion for this precious resource, which has been a major part of my professional life since I was a medical student in the 1970s. Today I'll speak to you and describe the VA. The VA provides a robust and rich environment for the veteran as a patient, the trainee, whether a medical student or resident as learner, and the attending surgeon as provider, teacher, and as investigator to meet and work in concert to accomplish the mission of the Veterans Health Administration. This healthcare, educational, and research environment is unique, yet similar to the academic medical center, and indeed is a precious resource to bring opportunities for patient care, learning, discovery, and scholarly achievement which are of great value and which are priceless and valuable and are cherished. The VA environment is also indeed a significant resource for patients to receive high-quality health care, for trainees to have opportunities and primary responsibility not otherwise available in other parts of the private health care sector, and for faculty surgeons to acquire clinical experiences which enhance their skill, sharpen expertise, and advance their careers. I had unique learning experiences and opportunities in my junior and senior year medical student rotations at the John Cochrane VA in St. Louis. I still remember my first operation in 1972, an AV fistula for hemodialysis. I assisted Dr. Rocco Fiordalisi, a beginning third-year surgical resident at St. Louis U, and our attending that day was Dr. Don Kaminsky, a now retired member of the Western Surgical. I especially remember this operation for the scrub nurse's role in Rocco's training. Rocco made several consecutive requests for specific instruments, and repeatedly, after each request, the male scrub nurse gave Rocco a different instrument. Finally, after 4 or 5 of these instrument passes, Rocco paused gazed at me over his mask, and with genuine appreciation complimented the scrub nurse, saying, "Thanks for helping me and for giving me what I need and not what I ask for." We all laughed, and especially Dr. Kaminsky, who had actually just returned from his research fellowship, as it turned out, from Dave Narwhal's lab out at Penn State to set up his research lab at St. Louis U. I remember this very early experience as a student for that teachable moment, the fun we had, and that the teacher was the VA scrub nurse. The history of care for veterans can be traced to the earliest days of our country. In 1636, the Pilgrims of Plymouth Colony passed a law supporting disabled soldiers, which stated, "If any man shall set forth as a soldier and shall return maimed, he shall be maintained competently by the colony during his life." More than a century later, in 1776, the Continental Congress provided pensions for injured soldiers. And in 1789, after the Revolutionary War was over, the U.S. Congress passed a law providing pensions to disabled veterans and their dependents. In the early 19th century, as our country matured and prospered, Congress expanded this support for veterans. In 1811, the first domiciliary and medical facility was mandated. During the Civil War, in mid-19th century, Union forces had 359,000 soldiers killed and 280,000 wounded, creating a large number of new disabled veterans. In 1866, after the Civil War ended, Congress established national homes for disabled veterans in Togus, Maine, Dayton, Ohio, and Milwaukee, Wisconsin. Interestingly, no care was authorized for greater than 100,000 wounded Confederate veterans until 1958, just before the last Confederate soldier died in 1959. Before his assassination in 1865, President Lincoln again affirmed our nation's commitment to its disabled soldiers with this famous statement, "To care for him who shall have borne the battle, and for his widow and his orphan." This statement is engraved on a plaque that greets all who enter the VA Central Office at 810 Vermont Avenue Northwest in Washington, D.C. In the latter 19th century, after the Civil War, benefits were extended to veterans of other wars, including the Indian Wars, the Spanish-American War, and the Mexican border disputes. World War I resulted in 116,000 deaths and 204,000 wounded servicemen. The Bureau of War Risk was created, and it authorized care for veterans in public health service hospitals, which numbered at that time 52 in 1920. In 1921, President Harding created the Veterans Bureau, which combined the public health service hospitals and the Bureau of War Risk while keeping the national homes and the Bureau of Pensions separate. Colonel Charles Forbes was the first director of the Veterans Bureau. He had many political difficulties, likely due to his delegating too many responsibilities. He resigned 2 years later in 1923, and the second director was General Frank Key Hines, a veteran of the Spanish-American War and World War I. He was quiet yet quite efficient. He avoided and overcame political crises, though had great difficulty recruiting physicians who disliked reporting to non-medical supervisors and administrators in civil service. A 34-physician council recommended medical school affiliations and hospitals managed by medical professionals and MD pay comparable to the private sector, as well as others. Many physician groups opposed these changes, and veterans perceived they would be used as guinea pigs. In the ensuing years, from 1924 to 1930, Congress failed to pass any of the 9 legislative bills proposed to change the Veterans Bureau. In 1930, President Hoover merged the Veterans Bureau and cemeteries with the Bureau of Pensions and the National Home for Disabled Volunteer Soldiers, creating the Veterans Administration, whose mission was to distribute disabled veterans' pensions and maintain domiciles for disabled veterans and to maintain the veteran cemeteries. In 1943, with World War II ongoing, Dr. Paul Magnuson, an orthopedic surgeon by training and in his early years practice, and a leader at the Northwestern University Medical School, proposed affiliations of VA hospitals with medical schools to increase physicians and nurses and other healthcare professionals in VA service and to train residents. In 1945, at the end of World War II, 17 million injured or disabled veterans sought health care stateside. The VA had few physicians and nurses and even fewer hospitals. General Omar Bradley then was appointed administrator of the VA, and General Paul Hawley, Surgeon General of the Army, engaged Dr. Magnuson's proposal for medical school affiliation. On January 3, 1946, President Harry Truman established the VA Department of Medicine and Surgery to, quote, streamline and modernize the practice of medicine for veterans, citing Public Law 79-293. The VA promptly published VA Policy Memorandum No. 2, which became known as the Affiliation Magna Carta. It was only 5 pages long and was written very concisely. First, it described a mutual understanding and cooperation between the VA and medical school affiliates. Second, it defined the memorandum's purpose to, quote, afford the veteran a much higher standard of care. Thirdly, it defined the responsibility as the VA assumed care of veterans and the medical school educated residents and medical students. And four, it defined the roles of VA administration, medical school leaders, service chiefs, and the full and part-time physicians and consultants. The next day, January 4th, 1946, the first affiliation with a medical school quickly occurred by no coincidence between the Edward Hines Jr. VA Hospital and 2 medical schools in Chicago, Northwestern University and the University of Illinois. And 56 residents began rotations at the Hines VA. To commemorate the 50th anniversary of this first affiliation in 1996, the VA and the AAMC placed a plaque in the corridor between the Ward and Terry buildings at Northwestern's Feinberg School of Medicine in downtown Chicago. The plaque is signed by then Secretary Jesse Brown, a disabled veteran and Chicago resident, now deceased, and by Dr. Jordan Cohen, still alive, then was AAMC president. Following this notable event back in '46, more than 100 academic affiliations were established, and 70 new VA hospitals were built in the 1950s. Medical specialties and hospital inpatient care was viewed as the best medical care. The VA hospital system grew along with its government bureaucracy. Nonetheless, VA hospitals were a rich resource for education of medical students and residents. In the last 40 years, the period of my professional life, the VA healthcare system has grown remarkably. In the 1970s and 80s, Vietnam veterans seeking care increased, and healthcare quality and access were very often criticized. In 1989, in an effort to improve the VA and its image, President George H.W. Bush elevated the VA to cabinet status, changing its name from the Veterans Administration to the Department of Veterans Affairs. In the 1990s, the VA was the largest healthcare provider in the country. There were 172 VA hospitals, 131 skilled nursing facilities, 206 counseling centers and other facilities. And the VA had 210,000 employees, and 1.1 million veterans were admitted per year. The VA was sometimes then described as indifferent, inefficient, and incompetent. In January 1994, President Bill Clinton appointed Dr. Kenneth Kaiser as VA Undersecretary for Health. Dr. Kaiser was a registered Republican and former head of the California Department of Public Health, and his vision was based on the well-known value equals quality divided by cost equation. In his words, in an integrated healthcare system, physicians, hospitals, and all other components share the risks and rewards and support one another. In doing so, they blend their talents and pool their resources. They focus on delivering best value care. To be successful, the integrated healthcare system requires management of total costs, a focus on populations rather than individuals, and a data-driven, process-focused customer orientation. Primary care and chronic disease management were emphasized while not ignoring acute care. Performance of all types was measured. Health information was increasingly managed electronically, and funding or reimbursement for basic and complex care was differentiated. During Dr. Kaiser's tenure as Undersecretary, the VA health system was transformed. From 1995 to 1999, many health system changes were accomplished. 22 Veterans Integrated Service Networks, or so-called VISNs, were created. 29,000 acute care hospital beds were closed, and bed days of care were reduced 68%. 350,000 fewer patients were admitted, while greater than 700,000 more patients were treated, an increase of 24%. VA staff was reduced by 26,000 full-time employees, a 12% decrease. 302 community-based outpatient clinics, or so-called CBOCs, were established and primary care provided. 2,800 forms of paper were eliminated, and most of the remainder were automated. 52 medical centers were merged into 25 multi-campus facilities. Expenditures per patient decreased 25%. Surgical cases increased 10%, and the proportion of ambulatory surgical cases increased from 35% of the total to 80%. Perhaps most importantly, the largest ever electronic medical record deployment and implementation was completed in less than 3 years. And I think many of us can remember that painful exercise, as those of us also are experiencing it now, even today, in other areas. The Veterans Health Information Systems and Technology Architecture, known as VISTA, and its graphic user interface, the Computerized Patient Record System, or CPRS, are open source EMR programs that have been adopted in many countries, including Finland, Germany, Egypt, Nigeria, Mexico, India, Pakistan, Uganda, Jordan, and recently Australia, while only a handful of US hospitals use it. There have been many notable VA process improvements in surgery from 1995 to the present. Attending surgeon physical presence at the point of care is much more evident. Close proximity to the attending surgeon has improved timeliness of decision-making and surgical treatments. Improved supervision and training of surgical residents and students is clearly evident, while maintaining a culture of delegated and progressive trainee responsibility. Better documentation of trainee supervision has occurred. Multidisciplinary patient management, so necessary in managing complex health problems, is now evident. Preoperative patient review and preparation is reliably accomplished by routine and systematic practices. Operating room and other efficiency initiatives have been welcomed by all healthcare providers as we provide high-quality care and more of it while being good stewards of resources. When complications and adverse events occur, mortality and morbidity conferences are now supplemented by focused review and discussions at many levels to regularly initiate system-wide improvements beyond the scope of the surgery service. As VA has quietly improved its systems of care and its overall quality, a recent book was published in 2010, which was well received, as one might expect, by VHA leaders. Philip Longman is a senior fellow at the New America Foundation. He's written and authored numerous articles and books on healthcare and public policy. Fortune magazine asked him to find the best solutions for a U.S. healthcare crisis. After significant research and inspired by his wife's 10-month futile struggle with breast cancer, he finished his book, now in its second edition. And two notable reviewers had these comments. Dr. Elliot Fisher from Dartmouth. Longman describes turnaround of the VA, recognized now as leading the nation in quality and cost, and offers insights useful to patients and policymakers. And Dr. Donald Berwick from Harvard, former CMS administrator, stated, students of quality improvement will find lesson after lesson in this important case study. Longman cites literature showing many specific improvements in VA healthcare, some of which include overcoming racial healthcare disparities, better quality measures than Medicare, better management of diabetics and numerous quality measures, greater life expectancy of VA elderly than comparable Medicare beneficiaries, the better inpatient satisfaction in veterans than Medicare beneficiaries, similar 30-day unadjusted post-op mortality after common general surgery operations, and VA mortality after CABG less than the private sector. In safety, Longman quotes Dr. Lucian Leap, who's known by many of us in this room as a surgeon, who states, VA has quickly emerged as a bright star, largely due to its long-standing leadership in quality improvement and information technology. Current VA healthcare can be characterized by its robust electronic medical records, CPRS, and VISTA, which supports all healthcare efforts to manage chronic diseases over a long term for a defined population. VA healthcare emphasizes primary care and preventive medicine, provides acute care and treatment when indicated, minimizes redundant diagnostic testing, all in an environment striving for optimal patient safety. When adverse events occur, they are quickly analyzed for quality improvement purposes and are fully disclosed to patients and families when appropriate. System-wide improvements in quality and safety are evident in all VA facilities. Education continues as one of the VA's 4 missions after more than 66 years since President Truman established the Department of Medicine and Surgery in VA. The VA's education programs are implemented through affiliations with 107 out of the 125 allopathic and 15 of the 25 osteopathic medical schools, with 26 out of 56 dental schools in the U.S. and with 1,200 colleges. Each year, more than 100,000 trainees in the health professions receive part or all of their education in the VA. This number includes approximately 34,000 medical students, including those, 34,000 medical residents, including those in surgical specialties, 19,000 medical students, 600 dental residents, and nearly 50,000 trainees in more than 40 associated health education programs. In addition, the VA independently sponsors health training programs in psychology, pharmacy, podiatry, optometry, and speech-language pathology. VA is the third largest source of funding for GME in the United States after Medicare and Medicaid. VA recently increased the number of funded residency positions from 9,000 to 11,000, which constitutes approximately 10% of the U.S. total. It's been determined by the Office of Academic Affiliations through a recent survey that 59% of all U.S. physicians received at least part of their education or training in the VA. Furthermore, through its annual Learners' Perception Survey, 85% of trainees rate VA training better than or equal to non-VA training, and 90% of trainees would recommend VA training to their peers. VA provides medical students and surgical residents a direct role in surgical patient care, albeit with close-up supervision by a faculty surgeon. Like many academic teaching services, VA surgical services use a team approach consisting of a faculty surgeon, chief resident, junior residents, and medical students to provide veterans surgical care. Mid-level providers, that is nurse practitioners and physician assistants, now are integrated into surgical teams to provide process of care continuity, support ADR work rule requirements, perform care coordination, and fill gaps in care and treatment when students and residents are not available. Medical students and surgical residents have numerous opportunities for longitudinal care involvement during preoperative, operative, and postoperative periods and in outpatient and hospital settings. Students and residents are intimately involved in their veteran patients' care and often perform preoperative processes to discuss, plan, assess risk, optimize and select patients, provide informed consent, render social and family support, perform procedures and post-op care with active supervision, and instruct patients at discharge and in post-op follow-up visits. Students and residents alike routinely are identified by the veteran as her or his doctor or significant caregiver, and two, receive significant expressions of gratitude and not infrequently receive gifts from their veteran patients for timely, sometimes continuous, and thoughtful care and treatment. The quality and quantity of these experiences occur much less frequently in private sector teaching settings where insurance reimbursement mandates the faculty surgeon to be very close to the patient, and the trainee all too often is in the background. In Dr. Bill Cheadle's 2005 presidential address to the Association of VA Surgeons, he described the many facets of the VA research program. Its portfolio is broad and covers military, occupational, and environmental exposures, service-related limb loss, acute traumatic injury and traumatic brain injury, aging, mental illness, diabetes, cancer, chronic disease, and special populations like blind and spinal cord injury. There have been many highlights in VA research over the last decades, including TB treatment, prosthetics development, blind rehab, implantable pacemakers, concepts leading to CT scanning, the first liver transplant by Dr. Starzl at the Denver VA, the nicotine patch, computerized ventilators, the insulin pump, colonoscopy screening, and inguinal hernia repair. Numerous VA cooperative trials have been highly successful in cardiac surgery, 8 of them since 1965. In vascular surgery, at least 7 of them since 1977, and various other surgical trials since 1983. There have been 3 VA investigators who won Nobel Prizes. In 1977, Andrew Shalley at the New Orleans VA for identifying hypothalamic releasing factors, and Rosalind Yallo the same year at the Bronx VA for developing the radioimmunoassay. And in 1998, Farid Murad at the Palo Alto VA for his finding of nitric oxide mediation of nitroglycerin-induced vasodilation. The VA's Merit Review Program that funded my lab for 15 years, Career Development Awards, and Health Services Research programs have supported scores of surgical investigators, some of whom are here in this audience today. Perhaps the shining star highlighting VA research has been the National Surgical Quality Improvement Program, or NSQIP. It's an outcome-based program which is risk-adjusted and contains validated clinical data, of which there are 45 preoperative, 17 operative, and 33 outcome variables entered into a database by trained nurse reviewers at each VA hospital. It was spawned by reports of poor surgical results in the VA. Congress mandated the VA to compare surgical outcomes to the private sector. From 1991 to 1993, the National VA Surgical Risk Study entered numerous clinical data from nearly 84,000 patients into clinical databases, and a risk stratification index was developed. Participants were the 44 VA hospitals that performed cardiac surgery. Data were analyzed and hospitals were ranked by their observed to expected, now famous OE ratio of mortality and morbidity. These results were provided as feedback to participating hospitals, and the hospitals with the lowest or best OE ratio identified best practices and care processes that were passed on to those with highest OE ratios, and process improvements were implemented. In 1995, the methodology was rolled out to all VA hospitals. NSQIP identified 5 significant risk factors predicting postoperative mortality, and you've all heard them probably many times: serum albumin, age, an emergency operation, high ASA class, and disseminated cancer. Over the course of the last 20 years, from 1991 to 2011, VA surgical mortality rate, unadjusted, has decreased nearly threefold. Many credit the VA transformation for improved post-op 30-day mortality and improved surgical outcomes to NSQIP, as demonstrated in this graph of VA 30-day unadjusted post-op mortality for the recent 21-year period from 1991 to 2011. VA unadjusted mortality rate over this period progressively fell from 3.2% in 1991 to 93 to 1.2% in 2011. Ladies and gentlemen, as I end this presentation, I thank my mentors, Dr. John Waldhausen, here in your upper left. Dr. Waldhausen passed away this year, and Dave Narwhal just below him. And I thank all my colleagues from Northwestern and Loyola, especially Dr. Jim Yao. You can see Jim there in the lower left, Bob Reed, who introduced me earlier, Rich Gamelli, Jerry Rana, Jeff Silver, and most recent chair, Dr. Paul Koo, whose student presented a paper so well earlier today. I also cannot thank my family enough for all their support and tolerance over many decades. My wife, Julia, you can see this picture was taken at Hannah's graduation at Spring Hill College in Mobile. There's Julia, here's Jake and Sam. Hillary's an NP. Sarah, who is an occupational therapist, though isn't working right now. Claudia and Hannah. And then Sarah and Mark, pictured here just after Maya Jane's birth, with our grandson, Owen. We've all been concerned that Owen wouldn't accept his little sister so well, but it turns out that he's done quite well with that. And Owen's here sitting by me. We're watching a football game, and he has all of his mother's expressions. Anyway, ladies and gentlemen, I appreciate your attention, and I hope you enjoy this 120th meeting of the Western as much as I have enjoyed them since my first one in 1987. Thank you for this honor and privilege.